All right, welcome back, and thank you for creating time for us as we shift gears into the health segment, health and lifestyle, talking about focus on cancer, the awareness that we need to create as we take stock on the progress we are making as a country in tackling cancer this particular day. And I told you that I'll be hosting a panel that has an expert and also somebody who has a lived experience having lived with cancer. And her name is Eunice Mwende. She's a breast cancer survivor. Currently, she is still on the journey, and she'll tell us how she has been able to inspire herself and even inspire others to be able to tackle this better. And of course, this morning we also have Professor Mansoor Saleh, who is a medical oncologist at Aga Khan University Hospital. Asante for creating time for us this morning. Of course, I cannot begin this conversation before I acknowledge the sad news that we have received this morning of the passing of the Chancellor of the Aga Khan University. That is His Highness the Aga Khan, that occurred last night. Of course, you know, there's a lot that has been done with his charity in line of charity that has touched many lives in the developing world, and it's news that we are still, you know, trying to process. And I'd just like to give you a chance to, you know, say something as we begin this interview concerning that loss.
No, thank you. Thank you for acknowledging his passing. He came to Kenya when he was 7 years old. His grandfather sent him to Kenya during the Second World War, and he was a very good friend of Kenya. I remember him saying, when I was a mtoto, I lost a little rabbit in my home and I was very sad. And I think he came to Kenya very, very frequently, but I think that the people of Kenya, the people of East Africa have benefited from the Aga Khan Development Network and the work of the Chancellor, and I have benefited from his wisdom and training, and this is why I came from the United States to come to work at this institution here at AKU to do cancer research and educate and to treat patients like Eunice. So I'm grateful that you acknowledge his passing.
Yeah, true. It's a really huge loss, not just for the family and the people who knew him, but also the entire, you know, family of the developing worlds, where he has done a lot to be able to just make sure that he improved livelihoods, and that is going to be greatly missed. So it's a big loss for everyone. That's what I can say. As we begin this conversation, World Cancer Day every year on the 4th of February, a significant moment that I'd like us to just begin on a general note, Daktari, from where you sit, you know, how would you, you know, describe this particular day and its significance, and what usually happens around this particular time? What should be on the in tray as we mark the World Cancer Day?
We want to at least bring awareness to the fact that cancer is the most common cause of death today. It used to be infectious diseases, heart disease, cancer. Cancer has become number 2 after heart disease. But we're not very much afraid of heart disease. You get chest pain, you go to the hospital, you get a clot buster, you say, I'll get a bypass, I'll get a stent. It's not very life-threatening. But Eunice will tell you, cancer is a life-threatening entity. But we can prevent cancer, and we'll talk about it. The fact that HPV vaccination can eradicate 98% of cervical cancer, a very common cause of death in East Africa. We should do that. Mammography, if done early, will detect breast cancer very early and increase the life expectancy of a woman. Prostate cancer, the PSA test, is life-saving for men. So on this day, we remind ourselves that these things can be done, early detection, prevention, and we have great treatment. But I want to tell your audience to say, when I was a young kid in Zanzibar, my grandfather used to give me a shilling to go to a movie, and I would go to a Tarzan movie. For that 1 hour, I felt like I was Tarzan. I could talk to the animals, climb trees, talk with the monkeys. Come Monday, it was all forgotten. I went to school. We should not let the Cancer Awareness Day become a Tarzan effect, whereby today we talk about it and tomorrow it's all forgotten. But it is very important that we really recognize that we can prevent, detect, and improve cure rate of cancer if we make the effort.
All right, great way to start it. And, you know, Eunice, I'd like to hear from you. For some people who've not lived that experience, or they've not had anyone close to them, you know, diagnosed with cancer, it can be an event. But for you, it is a life that you have lived for so long. Tell us a bit about your cancer journey, and it's breast cancer. Tell us a bit about, you know, when it all started and how did you find out that something was off about you?
Oh, thank you so much for having me. My name is Mwende Mutiso Eunice, and I am 32 years old. I am the founder of a non-profit called Chasing Hope, which was one of the outcomes of the journey which I'm going to share. So I was first diagnosed in 2016 when I was 23 years old with stage 0 breast cancer, DCIS. And at that time, it was quite a shocker for me, for my family, mainly because I am the youngest in our family and we don't have any history of any type of cancer to date. So it was not something which we anticipated would happen. I learned, how I came to learn that I had breast cancer, it was just by chance that I had attended a medical camp and there was a cancer survivor who showed us how to do self-breast examination. And I used to do that regularly. So in 2015, end of 2015, I remember feeling something in my breast. I went to a clinic and I was told it's nothing. So it took about 6-7 months after visiting at least 4 different hospitals to get the first diagnosis. At some point in one hospital I went to, I was given antibiotics. You know, there was another hospital I went to and I was told, you know, it cannot be anything apart from, you know, it's just hormonal imbalance, it will go away on its own. But because of the persistence I had, and I had a bit of information about breast cancer, that is why I went to now, you know, I sought other opinions. So I got a diagnosis, and stage 0 is the earliest stage you can get it. And so I started my journey in one of the public hospitals. At that time, I didn't have any insurance, including NHIF. So it was quite challenging to get.
It was out of pocket.
It was out of pocket, everything. And because of that, so we were looking for the cheapest alternative. And as we know, cheap can be expensive. So at some point before my diagnosis, I did a surgery. Now I know it's called lumpectomy, removal of the lump and the surrounding tissues. And this was before the diagnosis. Since I was told it could not be anything really. So the diagnosis came afterwards, and when I was about to do radiotherapy, it was found out that the surgery wasn't done properly. So because of that, now I had to do another surgery, mastectomy, which is now removal of the whole breast. And this, I was 23 years old, so that was really, it was a difficult as a young woman, you know, living with now one breast. But at that time, since I was on autopilot, I just made the decisions quickly because I wanted to finish this process and go back to my life, as I had just started studying my degree of psychology and counseling. So after about a year down the line, after the mastectomy, at that time, after the mastectomy, since it was so early, I didn't do radiotherapy or chemotherapy. I was put on medication, a tablet a day called tamoxifen for 5 years. So after about a year, that's when it really, you know, my mental health was really a challenge. I got into depression because of now what I had gone through. At that time, I didn't know I needed to do therapy. And so I started doing therapy, and I learned how to now cope better.
With the journey.
With the journey.
I'll come back to you. Sorry to cut you short, because I want you to take a step by step. So was the procedure done, mastectomy, was it done for both, or it was one side?
One side, yes.
Diagnosed at 23 years, that is quite young.
Yes, absolutely.
Yeah. Daktari, just as you hear, you know, what she's sharing, and I want us to talk about the cancer burden, you know, because it's about, you know, the general cancers that we have. For her, at least she had awareness, and this is what led to her early diagnosis. But what are we looking at in terms of the level of knowledge that is out there, and how big this burden could be for those who've been diagnosed and even those who have not been diagnosed yet?
So we look at the lack of awareness on part of the public. It is uncommon to get breast cancer at the age of 23 or 24. Most women in North America will get breast cancer at the age of 60. So we say mammography start at 50 because at 60 is the most common age. In Africa, 20% of our breast cancer women are below the age of 40. Very few are as young as Eunice was. So clearly we don't see this as a big issue, but it is. But as you heard yourself from Eunice, she went to 4 different doctors before somebody could really take her seriously. So we have a lack of awareness also from the medical practitioner to say that this could be an infection, could be something else. So I think we need to do a 2-pronged approach. Make sure that the public is aware that this is for real, may not be happening at this particular age, but self-examination, very critical. And you do it automatically, just body image and just knowing your body is also very critical. When something is different, pay attention to it. And the problem we've talked about yesterday at a different show was we often do not have enough money to afford to go to a doctor to say, well, it'll go away. So even we ignore it to a certain degree. But when we do go to the doctor, I think the medical society is not acutely aware of the presence of cancer. And one thing we should be doing today, which you are, is to really make it aware to say it is the 2nd most common cause of death. When women come in with left-sided pain to the arm, most of the people will ignore it. Maybe it's just musculoskeletal. But what now we know it could be chest pain from a heart attack. Well, a breast lump or difficulty passing water when you are a man could be prostate cancer, could be breast cancer. That awareness is what we need to really inculcate on these kinds of events.
So in an ideal situation, what should be done so that we increase the number of, catching this cancer at the right time? Assume, and it's actually the reality. We do not have like as many oncologists as yourself in the country. We have, other cadres of health practitioners in the health facilities who meet these patients on a regular basis. So what should be the standard procedure in case, you want to really maximize on the opportunities that, people go to the health facilities to be able to catch this cancer early, even if you're an expert on matters cancer or not? What should be the standard procedure?
So let's talk about the most common cancer in women. Breast cancer, cervical cancer. Mammography for breast cancer at the age of 40. Cervical cancer, the best way to eradicate cervical cancer is vaccination. If you vaccinate our boys and girls at this age of adolescence, we will eradicate 98% of cervical cancer because cervical cancer is caused by a virus, the HPV virus. So Eunice went to a camp, an awareness camp. We should have more camps. You don't need an oncologist necessarily, but a healthcare provider, a community healthcare worker can teach you how to do breast examination. You do it in the privacy of your home on a monthly basis. And then when you're at the age of 40, you come and have your mammogram. We should make it a little bit cheaper to have a mammogram through NHIF or SHIF or SHA, and that we should be doing as a society. Vaccination for HPV, important, but then a pap smear. When you are sexually active, at the age of 25, you get your first pap smear, and they determine how often to get it thereafter. For a man, usually above the age of 50, the PSA test is very, very important. Just a blood test to say, is it elevated? If it is, you're at risk for prostate cancer. So those are the most common cancers we think about.
This test you do, regardless of whether you're showing signs and symptoms or not?
Absolutely. So mammography, absolutely, whether you have a family history or not, should be done. Pap smear, these are all early detections because there's no other way to pick it up early. By the time you pick it up, when you have symptoms, it is metastatic disease. The cure rate drops from 90 to 100% down to 10%. So metastatic disease is when the tumor spreads from the site of origin into the bloodstream and everywhere else. Now you've got to chase it with chemotherapy. It's like having to give fertilizer because the weeds have escaped all over the place. If you can get that one weed early one morning and pull it out, the garden is done. And that's prevention.
Yeah. What about the health workers, the professionals? On their part, what should they do? What should they look out for? I
think we should educate our physicians, but also the community health workers and the nurses, because the people that Eunice and others will seek first
before they see people like you.
Exactly. Yeah. Now, we had a meeting yesterday, Eunice and I. Even the we call them the mganga next door. Even the mganga next door need to be educated that this plump would well be breast cancer. So while he can do his magic or whatever he does, at least he or she should refer the patient. If it does not go away within 2 weeks, go and seek help with a medical professional, a nurse, a physician, and those should be affordable. if we make it affordable, we will prevent more deaths. And that is, I think, one of the reasons we're here today.
Yeah, true, true. Eunice, take me back to when you got this news. At 23 years, that's not what you want to hear. For a young person, you're thinking about so many things. You have plans. And you also mentioned, you know, this journey took you to the point of you are sinking into depression. Talk to us about your thought process, receiving this news at that young age, that you have cancer. How did you feel? What was happening in your life around that time, and how did it cascade to depression?
So when I got the news, when I first got the, felt the lump, I was in university. I had just started my degree. So my life was, I was in university. I had an internship at an NGO. So my life was really moving. And now when I got the news, I can remember the day, the moment I was told I had cancer. And the doctor who was informing me he just told me the news, because to date I cannot tell you how I got home. So it was a shocker for me. I was not prepared. Yes, he just told me, so now I've looked at your results, and yes, you have breast cancer. So now you need to go and have a mastectomy. You need to start chemotherapy. I was alone, so I didn't expect that. I knew there could be something, but of course cancer was not what I thought it would be. So the delivery wasn't very humane, and that is a challenge which I know not just me, but quite a number of patients have come across. When you're being told that you have a life-threatening illness, and they don't, some doctors don't tell you that you might need to come with somebody else to just, for the support.
System. Yeah.
Yes, and to just also, check how you are mentally before just telling you the information so that you can process. So it was a shocker. But you see, after the diagnosis and going through depression, seeking therapy, when I got my second diagnosis in 2019, I took the news much better because I knew there could be a chance of a recurrence. So as much as I was told it's very minimal since it was caught very early, there's always that thought that there could be a recurrence. So it's a challenge.
Okay, allow me to take you back a bit. So there was that procedure that was done for the 2015 one?
2016.
2016.
Yes.
So 2019, we are back here again?
Yes, 2019. So I was on the medication, the tablet, and I found a lump again on the scar where the mastectomy was done. And I saw the lump actually in 2018 around December. Went to the hospital, but it was ruled out as a cyst. So I didn't pay much attention to it. About 7 months down the line, I remember feeling some lymph nodes here which were swollen. I had a cold, so I thought it could be a cold, but after the cold passed, they were still there, no pain, so I went back to the hospital to have them checked. I did biopsy for the lymph nodes and the lump which was now on the scar, and it showed that the cancer was back. So when I did a full body PET scan, that's when the doctor informed me that it had also gone to one of my lungs. And I got this news a day before my 27th birthday. And it's something I thought, I was done with cancer. So again, I felt like my life had again been, flipped upside down since I had resumed university again. And at that time, I've watched so many movies. So I remember just asking the doctor, so what is my prognosis? And
also, you are now becoming...
Yes, I was, reading research, yes. And I also wanted to know what's happening in my body. What questions should I ask the doctor? What information do I need? Because I also, when I got the first diagnosis, I was very green. I didn't have enough information. And because of that, I ended up making quite a number of mistakes, not necessarily on my end, but even the professionals who I sought advice from, they some of them didn't know exactly what the procedure I should follow. So I remember just thinking, you know, I needed to know more about what's happening. So when I went back and I asked about my prognosis, again, the doctor who I saw, I asked her, and then she told me, I think you have another 1 year with us. And you know, you remember,
casually.
yes, so casually. And I remember when the person I was with thought the doctor meant the treatment will last for 1 year. But because I already knew it's stage 4 and I knew it's not curable, at that time, my mentality, my perception was much more different. So I started a bucket list, you know, writing items of what I wanted to do within these 365 days. And initially, I actually didn't want to do treatment, but, you know, through persuasion and hearing some stories of people who have actually gone through this and they have survived more years than the prognosis they were given, that's one of the reasons I decided to now seek treatment.
All right. I'll come back to you so that we talk about what nature of treatment, you know, this was, and how did it take a toll on you? Like, what was the experience? But Dr. just hearing what she is sharing, her biggest concern, I think this is a concern for many cancer patients who've gotten their diagnosis, is how the news is usually delivered. And I'm looking at the state of mind of this patient, and how that state of mind, from what I've interacted with, is really playing a role in how they are going to fight this cancer better. So as oncologists, whenever you're met with this moment where now you have to like deliver the news, no matter how hard it is, how do you do it in such a way that you will not lose this patient on the day they receive their diagnosis? Yeah.
So I'll tell you how we do it at the Aga Khan University. We have now a medical school where we train. When I was training many decades ago, you didn't go through this process. Yeah. The first patient you meet was the first experience you try to give the news to. Now we have role plays. You have an actor who's told, you have breast cancer, play the role. You come to see me, the medical student. And the medical student is told, you've got a breast cancer patient whose pathology you know, how are you going to give her the news?
Yes.
And you're being videoed, so you know exactly what you're saying, you prepare yourself, and then you get a feedback from this actor patient, and you get a feedback from your professor who say, by the way, the news you broke out wasn't the right way, this is the way to do it. So we learn much better. So there's
a way of doing it.
So that's one thing. Secondly is, Eunice's story is very unusual. With DCIS, which is really, it's a precancer. And if you have a mastectomy, the precancer is gone. That breast is gone. There should be no precancer.
Yeah.
The fact that you recur at the scar and maybe in the lymph node elsewhere says somewhere down the road a diagnosis may have been missed. It may have been aggressive, invasive cancer. So certainly this is not the reality of what should happen usually. Often what you do is when you get a lump in the breast, the first place it spreads to is the lymph node in the axilla. So when we do surgery, you remove the lump, remove the axillary lymph nodes, see if they are positive. If they are positive, then the risk of cells having spread outside is high. You get hormone therapy or chemotherapy. But let me go back. Today, after we role play, and we're able to give the news very effectively, we at AKU will say, you the patient, you the family member, come and meet the surgeon, the medical oncologist, and the radiation oncologist. We'll give you the journey. Because often the surgeon says, I took it all out, it's done. And then you get a call from the oncologist, say, by the way, come next week, we need to give you chemotherapy. Well, I didn't hear about that. And when the chemotherapy is finished, you get a call from the radiation oncologist to say, by the way, you got the lumpectomy, we have to give you radiation to the rest of the breast. Well, I didn't hear about that either. You may have heard of it, but there was so much news coming to you. So we have what we call a multidisciplinary breast cancer clinic, where pro bono, the patient, the family, sits there, gets the entire journey, asks questions, and then the journey begins. That's how we should do it for all cancer, so that we really are able to provide the patient the best information, especially also the caregivers, because cancer is the disease not only of the patient, but the caregivers affected as well. So we have a study going on, for example, that says how the brain ages as you have stress. And cancer is a stress. So we look at the MRI of a patient, we do psychological analysis before treatment, after treatment, both for the patient and the caregiver to see, is this stress aging your brain? So there's new studies today that allow us to be humane, better physicians in response to the patient. But most importantly, we have to inform the patient to be also aware of their bodies so they can come to medical attention much earlier.
All right. And that's important because considering the fact that we are talking about lack of awareness, there are so many people who are hearing about cancer seriously the very first time when they're getting their diagnosis. Like they've never interacted with what cancer is and all those informations. And here you are bombarding them with the diagnosis. Already you're also telling them about these big jargons of the procedures they have to go through all in the same day. And their thought process is still trying to allow the cancer news to sink in. So I think that's pretty much a fair approach, to break it down into small chunks so that this person is able to respond better to this journey. But then, Eunice, just tell me a bit about, you go to a point where you're a bit positive about this journey and you are willing at least to begin walking the treatment journey. Talk to us about how that was and what was done. The first time it was a mastectomy. This time what was done, and why did you have the benefit of having the knowledge about the other options that were there and settled for the specific one that you went through, and why?
Okay, thank you for the question. So as Dr. would, shed more light on it. So when I got this second diagnosis with stage 4, what I understood is that with the treatment, you start with the mild treatment as you progress.
Yeah.
Yes. So the first line of treatment, which I had done, now the tamoxifen had failed. So I started with, I did chemotherapy, oral chemotherapy, and targeted therapy as well, called Herceptin, and I was doing Zoladex injections, which is hormonal blockers. I think Dr. will shed more information.
These things is quite impressive.
Yeah, I had to learn some of these terms, yes, and to also know what to expect. Yeah. So one of the things I'm really grateful for is that I was able to get now my treatment at actually AKU when I got the stage 4 diagnosis. And because of that, as Dr. has shared, I had different professionals who were giving me information. So I understood more in terms of the treatment, what needed to be done and how, why and how, for how long. So my treatment was 5 sessions of chemotherapy every 3 weeks. I did a session, and then the targeted therapy, which is the Herceptin, I was to do it every 3 weeks for as long as it works. But because now of financial constraints, because it's not cheap, it's quite expensive to treat cancer. At that time, my insurance, NHIF, and the private covers I had, they all depleted, and I had to start paying out of pocket again. And for instance, with the Herceptin, it was approximately 100,000 every 3 weeks, and I needed 17 sessions a year, so that's every 3 weeks. NHIF at that time was only covering 4 sessions. My private cover was covering about 5 sessions, and then I had to pay out of pocket the rest. So by some time in 2021, I had to stop the Herceptin, and but I was doing now hormonal therapy, some tablets, letrozole, and I was also taking the injections, the Zoladex. So that is how with my doctor, we decided to manage the cancer, since I couldn't do the Herceptin. And one of the challenges I remember having was getting a medical cover. So even if you have money to pay for the premium, I applied countless times for this, medical covers, and none of them could take me. I went to different cancer organizations which support cancer survivors with their treatment. They couldn't take me also because I had stage 4, and that was a hard pill to swallow, knowing that NHIF is not paying enough, the private covers, insurance are not accepting me, the support, the cancer organizations which usually pay are not going to pay because I have stage 4 cancer. So, and this is a huge challenge which I found, especially with people with stage 4 cancers. We fall in the cracks. You really don't have anywhere to get support unless you're paying out of pocket. But how sustainable is that?
That is it. Yeah, I mean, and even as you talk about the financial drain, which is a reality. We can already see that, considering the advanced treatments that you needed to have gone through. Talk to us about the other side, the physical, the emotional. When you're going through a cancer treatment journey, what does it look like physically, emotionally? What goes on, and how did it take a toll on you as well?
So physically, there are the side effects, the fatigue, nausea. But you see, every person has different, there are similar side effects, but it depends with the person. So for me, I remember at some point I was quite ill. I had allergic reactions, but they were being managed at the hospital. I had my mental health, was it was a roller coaster. Most times, yes, I was happy and I was optimistic, but sometimes when you're just alone with your own thoughts, and then you start realizing that, there's actually no cure for this disease, and I know there's nobody, I haven't met anyone who would like to have a cancer diagnosis. So it was tough because I also have dreams and goals, and I had, not just 10 5-year plans, but looking at a bigger picture, thinking of how I would be when I have a family, when I am a grandmother, So, and I remember when I got now the second diagnosis, and the oncologist did advise that I shouldn't get pregnant. So the chances were also very low, but I also was advised not to get pregnant because of now this diagnosis I had. So that again was a blow because, I wanted to have that option of deciding whether I would like to have children of my own. And, as fate might have it, in 2024, last year, I had a baby, actually. Right. So I have...
Don't take us too fast.
I shouldn't go too far, okay.
Yeah, don't go too far too fast. Yeah? We'll talk about that shortly, but let me just finalize with the treatment, Dr. as you take us through what treatment options are out there right now. Because for a very long time, we've come from a background where cancer was treated as a death sentence. Especially her fears, stage 4, when you mentioned stage 4, then the red card is already on the table. Talk to us about the treatment options and what usually is considered while choosing one over the other to advance to the level where we can have the likes of mastectomy, vis-a-vis, just the drugs. Just run us through what you consider to choose.
So before I go to the treatment, let's talk about this issue about distress, anxiety, depression.
Yeah.
And we recognize that the oncologist is trained to cure, to save a life. We become oblivious of the fact that it has an effect on the mental health of the patient. So at AKU, we have what we call Distress Assessment Response Tool, call it DART. We DART every new cancer patient who comes in to say, look at the distress level, and depending upon the distress level, anxiety, fear, stigma, we provide counseling. Because that really helps them be more compliant and come to the doctor more frequently. Eunice mentioned targeted therapy. So the breast cancer cell has receptors, which are like small mouths, microscopic mouths. The breast cancer's fertilizer is estrogen, the female hormone. So the woman who's producing estrogen in the ovaries is really fertilizing her own tumor. So one of the treatments, and her tumor had the estrogen receptor, so we blocked the estrogen receptor with what you call was tamoxifen. She also talked about this term called Zoladex. When you're premenopausal, your ovaries are making so much estrogen, I can't block the mouth completely because so much growth factor coming in. So we give you a shot to make you postmenopausal, so your ovaries are not making any hormones anymore, so that whatever little bit is being made in your fat tissue, we can block from getting to the tumor by giving you the blocker of the receptor. So that's one.
All right.
She talked about Herceptin. You know, in addition to the estrogen receptor, there's also what we call the HER2, HER2 receptor. That's also another growth factor. To treat her tumor, we block the HER2 receptor with a drug called Herceptin. So today the treatment is not just a machine gun of chemotherapy that kills everything good and bad. We can at least target, in addition to keeping chemotherapy that is required, we can target the tumor specifically based upon what is fertilizing the tumor and how can we block that mouth where the fertilizer gets into it. And very soon, at AKU and hopefully elsewhere, we can identify the gene responsible for that breast cancer and block the gene. So we have a study that I am the principal investigator of, the first study in Africa, where if you have this particular gene, it's called the KRAS G12C gene. It's a bad gene that causes cancer. If you have that gene today, if I drew a blood test on me, and if that gene was positive in me, I've got a 98% chance that I will get cancer in my lifetime because that gene is cancer causing. Well, we do not know when, but it might happen.
Yeah.
But if it does happen and your tumor has that particular gene, we have a pill that blocks that gene. So we've gone from machine gun therapy, chemotherapy, targeted therapy, to very soon genetic therapy. That is advancement. But let me get to...
That is the space we are getting into.
Correct. And
this gene, can it be detected? Okay, it's a futuristic kind. Would it be detected in children or at any stage in life?
So if you have a hereditary cancer, like the BRCA gene, the Angelina Jolie gene, whereby you have a familial predilection to cancer, it will be detected in the young child.
Right.
But you'll have a family history. But most of us, 90% of cancers are not familial. So you can't detect it at the beginning, but it'll be detected somewhere down the road. But just to answer your question, if you have a lumpectomy, the rest of the breast is left intact, you need radiation therapy. If you have a mastectomy, you do not need radiation therapy. So you have two options: to save your breast, but to have radiation, or remove the breast and then to either have reconstruction. But because you have to have the surgery of the axilla, because that's where the lymph nodes are, this is the first stop where the cancers will spread. If your lymph node's negative, the likelihood of spread is very low. Lymph nodes positive, high likelihood, that's where you need more chemotherapy.
All right.
So those are the tests we do.
All right. There's a trend that happens. Sometimes you find women who are even in the initial stages of breast cancer opting for mastectomy as the option they want, in fear that they just want to end this now and not continue with this journey longer. Is that something you're observing in the medical world, and would you advise that we take that route?
So, as I said before, for breast cancer, lumpectomy plus radiation therapy is equal to mastectomy. There may be some women, so we give them a choice. It is your choice because the outcome is the same. So at that particular multidisciplinary clinic, the other day I had a patient come in and the husband says, I'd like to take it out completely because I don't want my wife to worry about it. I'm looking at the wife. The wife says, you know, the breast is my personality. It is my identity. Is there any way I could preserve it? Sure, yes, you can. So a mastectomy may be overkill for a small tumor in a small breast because, well, no, a large tumor with a small breast, you don't need to do a mastectomy. You could do a lumpectomy with radiation. But the woman might say, my breast will remind me that I might have something cooking in there. I don't want to have it. I'd rather have it taken out and reconstruction, the option. The other person will say, I want my original breast. It makes me feel who I am. So it's a patient's choice. If you look at it in North America, 60% lumpectomy, 40% mastectomy. In Africa, 70+% mastectomy, 30% lumpectomy, because people say, Nataka, out. Sitaki, to feel it anymore. And those are the decisions the patient has to make. But from the oncologist side point, the outcome is the same.
But do you see a trend where that is slowly becoming like a preference for most patients? And what would you advise as an oncologist?
So, let me tell you, in my lifetime, and I'm not sure how long I have to live, we will not even need to do a mastectomy or a lumpectomy. It used to be when I was training, you had a breast lump, we took out the lump, lumpectomy, radiation, or mastectomy, and then said, by the way, your lymph nodes were positive, they may have spread cells, so we'll give you chemotherapy. But you already taken out my breast, and you've taken out my lymph nodes. Did the chemotherapy help or not? I would not know. If the disease does not come back, chemotherapy helped. If disease comes back, chemotherapy did not help. Today, we give you chemotherapy upfront. That tumor will shrink. If it is shrinking, all the other cells that have escaped will also be killed. We have a study that we just completed, targeted therapy that Eunice talked about. 8 women with a big lump in the breast got chemotherapy and targeted therapy. All 8 at the time of surgery had no cancer in their breast or anywhere else. If that treatment is so successful, there'll be a future whereby, say, you give the chemotherapy before you're doing surgery, you do your blood test to say, are there any cancer genes in your blood? Negative, no mastectomy or lumpectomy required. That is the future. It is a future we are aspiring in Kenya just as well as we're aspiring in North America. That is the future. But before we get there, we need to create awareness that women come early. Physicians become more aware to say, don't let them go to 5 doctors before you make the diagnosis. That is where we are here today.
All right. Eunice, coming back to you, the biggest fear for cancer patients is really what you started mentioning, the fear that this journey may mean you may never have children of your own, considering the side effects. Talk to us about also that aspect of your journey. And now you're a mother. Tell us a bit about how that panned out.
So with, fertility, I have to say, initially when I started chemotherapy, I didn't have that conversation with my oncologist. So we had, I remember I actually brought it up after my second chemotherapy. That's when I remembered, by the way, we need to talk about, fertility. It's something which we had not talked about. So when I went to the doctor and I told her, I remember she also told me, okay, this is actually a conversation we should have had before you started chemotherapy. And, she referred me to a fertility doctor to go and hear the options I had, egg harvesting and what have you. But now the challenge there was, again, the finances.
Cost.
It is expensive. Yeah. So after hearing, the cost implications of getting this done, I knew I could not do it because I had to choose. Already I had stopped going to university to direct my funds to now the treatment. So I couldn't start, looking for funds to now do the procedure. So I just continued with the treatment, knowing that the likelihood of ever having a biological child would not, was now a dream, really.
It's shrinking.
Actually, it was not there anymore. I knew it will not happen. And so that was in 2019. I went through, the treatments and what have you. By 2022, I had to stop treatment. Since, as Dr. has said, with stage 4, the treatment is continuous, for managing the cancer. So I had to stop the treatment again because of finances. And it was also mentally exhausting to just know that whatever funds you're getting, I was working, but whatever funds I was getting, I was just directing it to the hospitals because it's either NHIF or paying out of pocket. And because I wasn't doing active chemotherapy or radiotherapy, the NHIF was not paying anything. So it was easier for me to just pause and I stopped treatment. But what I was doing is I used to still do the checkups, doing scans to just check the progression. So by around September 2023, when I was after I did the full body PET scan, it showed that I had a recurrence, a nodule recurrence. My organs were okay, including the lung, which had, a nodule which was, it was inactive. So I had no evidence of disease since 2021 to now 2023 September. And as I like to say, I have a tumor in my lung which is not paying rent. It's just there. It's not, but it's not active. So when I got the results and I had that, I knew that I had the recurrence, but just a nodule recurrence. So it wasn't too bad. But I now started the process again of of seeking treatment, because the idea is also to manage it so that it doesn't spread. And during that process, I got pregnant. And we had a very tough conversation with my oncologist, because she was informing me, you know, the medical aspect of being pregnant with a recurrence and having hormonal positive breast cancer. So, you know, I was given the options, and one of the options is actually termination. And, you know, and I was told if I decided to keep the pregnancy, then I would need to start chemotherapy. I would probably need to start chemotherapy after the first trimester. So it was quite a difficult decision.
A dilemma, considering this is something you have wanted for a very long time.
Yeah, and something which I actually forgot about, and then, you know,
just like a gift.
Yes, and then now I have to choose whether I'll keep the baby or not. But, you know, through, of course, a lot of consultation tests, I decided to keep the baby. And after the first trimester, when I was now going for review to check if I'll have to do chemotherapy, I was physically okay, and that, you know, the red flags which the doctor was looking out for were not there. So I didn't need to do any chemotherapy during the pregnancy. And yeah, to date, I haven't done any treatment, but now I need to resume since my baby is now 10 weeks old. So yeah, now I'm back in the process of resuming
the journey of treatment.
Yes.
All right, congratulations.
Thank you so much.
It's something that doesn't happen often, especially when you're in the cancer treatment journey. But Dr. just to pick up from where she has left, the fertility concerns for patients who are battling cancer, what are the options? And usually, you know, just what future are we looking at in terms of even preserving that for patients? Because you can imagine losing your breast and also losing that privilege of ever bringing forth life into this world. This is traumatizing for any woman in the reproductive age.
So Eunice is a living example that you can live with cancer, just like you can live with diabetes. It doesn't have to be a death sentence, so at least there is hope, whereby there is enough treatment to keep things moving, and we will stall the progression of disease. So at least this is a living example that, yes, there's always hope. When you get chemotherapy, the chemotherapy most likely will cause your ovaries not to produce any new eggs. So you'll become postmenopausal very quickly. If you want children, and we make you postmenopausal, that is counterintuitive. You want to keep your eggs fertile and really be available for a future pregnancy. So how do we protect your eggs while you're taking chemotherapy? We either remove some, extraction, freeze them, expensive, and then you do in vitro fertilization. Or we give you some medication, she talked about it, Nolvadex. That medication, in a way, puts your eggs in a pause state. They don't multiply, they don't replicate, they are quiescent in your body. So as I'm giving you chemotherapy, since your eggs are not replicating and multiplying, you're not having any periods, your eggs will not be affected per se. 50-50 chance that this will work. The other 50% chance that even though we stop the eggs from multiplying, they were, and you become postmenopausal. So multiple options then. You do egg preservation. We can either remove the eggs, we can either remove part of the ovary and freeze it away, costing, or we give you this medication to, in a way, freeze your eggs in your body, in a way, put them at standstill, and then 50-50 chance that if you do have your periods back, you can then become pregnant. But during the entire time, you've got to figure out, am I taking treatment? Am I taking a pause? Is the clock ticking? Is the cancer spreading? So there's always the dilemma. We have to work with the oncologist, the fertility specialist, and the patient.
For some patients who have made the decision to, for instance, take a break from treatment to have a child, is that a risk factor?
If you have metastatic disease, now for breast cancer, especially if your tumor is estrogen receptor positive, where your female hormones are the fertilizer, and you become pregnant, your estrogen levels are sky high, so you really are fertilizing the tumor significantly. We can take a break from chemotherapy as long as we are, like Eunice, watchful very carefully. Because the tumor is not multiplying like weeds usually. It's got a growth rate. We might say we can take a pause in between. You know, pregnancy is 9 months.
Yeah.
The first 3 months of pregnancy, we cannot give you chemotherapy. We can give you hormone therapy maybe, but even that you cannot do for breast cancer, especially if your tumor is ER positive. So we can say, yes, these 3 months are sacred, no treatment. Then we follow you very closely, and as long as the patient is willing to say, yes, I need treatment now, my tumor is progressing, the baby is safe in the womb. So there are ways to be able to manage this, but it's unusual to be able to preserve your ovaries, become premenopausal, become pregnant, and in this time when you are not taking a treatment, your disease is not spreading very much. So luck is always we'd like to have luck on our side, and I think Eunice had it as well.
And I like your optimism, Prof, you know, at least painting a positive, you know, image around how all this can be handled and how the options are out there. I want to give you 30 seconds each. Let's close this conversation as we are marking the World Cancer Day, which was actually yesterday, but it's the entire, I think it's a conversation we should sustain. What would be your clarion call as somebody who has lived the experience?
I would say as much as cancer is scary, we need to know that there's hope out here, you know, and I would urge people, especially the, you know, young people, youth, you know, to be doing annual checkups, you know, to take advantage of these medical camps which happen, and they are usually free, to take advantage, to go be checked, to do breast examinations, you know, because once, as the doctor said, you know, you need to know your body so that if there's something amiss, you can go to the doctor. If you go to a doctor and you feel you're not content with what you've been told, go seek a second opinion. So it's important to know your body. It's important to also to go to a healthcare facility which is credible, where you know you will get the good treatment. So yeah, and at the end of the day, there is hope.
Thank you. Daktari?
We've not talked about it a lot today, but clearly research is important, that we should do more research on our patients. Most of the research that has been done is on Caucasian patients in North America, not on the African patients. So I spent my entire career in America. I came back here 5 years ago because of the chancellor who just passed. In 2011, he said there are two things shortchanged in the developing world. One is research, the other one is education. We talked about education today. Educating our physicians to be more active about cancer, educating the population to be aware. Research we did not do. So I came to Kenya to do research at the Aga University. Today I can say that our research on specific areas are as good as anywhere else. And the motto of the research program is the drug called hope, Tumaini, whereby we have new treatments. We just have to be encouraged to be able to really face the odds and realize that there is hope in treatment.
Thank you. Professor Mansoor Saleh, medical oncologist, Aga Khan University Hospital. I was also having this conversation with Eunice Mwende, breast cancer survivor, sharing with us her lived experience. And she's here to prove that you can be a cancer warrior and a mother, a parent at the same time. So it's not all doom and gloom. Cancer is not a death sentence. Be optimistic, be positive, embrace your journey and fight like the warrior you are. My name is Safina Chingoma. That's how we wrap it up. Thank you so much for creating time today, and keep watching Citizen Television.